we'll 1 or 2 minutes we'll wait.
Yeah.
And then
Start.
Swaksha, you let me know when to start.
Yeah. Like already streaming has started, ma'am.
Yeah, let the
Yeah.
people join in.
Yeah.
They're
Yeah.
joining.
Right. 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 Ma'am, you can start 11
Yeah.
in Zoom and 6 have joined in YouTube. I think so till now.
Yes. I
You can
think you
start.
should mute some noises coming from some system.
Okay, I'll
Mr.
just
Padmanabhan, can you mute?
so Padmanabhan. I'll mute it. Yeah.
So I'll
Yeah.
start now. Yeah.
Yes.
Sir, I'll go,
Yeah.
Dr. Arun. Yes, sir. Good evening, everyone. It gives me immense pleasure to welcome you all to this evening's webinar, which is titled some issue. Yeah, optimizing management of primary biliary cholangitis. We all know that primary biliary cholangitis is an autoimmune cholestistic liver disease. Without treatment, most PBC patients eventually develop hepatic fibrosis and may require liver transplantation during the last stage of the disease. UDCA still remains the first line of therapy, has been proven to normalize serum biochemistries, halt histology diseases, and also halting progression of fibrosis leading to longer transplant-free survival. Today, we have a very distinguished speaker with us who will be discussing about what is optimizing management of treatment in the primary biliary cholangitis and what are the advances happening, what are the new drugs which are in the pipeline. So I have a great pleasure and the privilege of introducing and welcoming Dr. Arun. Doctor is Assistant Professor of Gastroenterology at Department of Digestive Health and Diseases, Chennai. He's a consultant at Apollo Main Hospital, Creams Road, Chennai. He is also director of Chandra Gastro Liver Clinic and Endoscopic Center, Chennai. His area of interest include post-liver transplant immunosuppressive guidelines and plasmapheresis in acute and chronic liver failure. Sir has been a member of various professional associations. To name a few, he is a life member of ISG, INASL, SGEI, and IAP as well. And also he has got several publications to his credit and several accreditations. Since the paucity of time, I have briefed it up. Sir, Dr. Arun, most welcome to you, and it's our privilege to have you, sir. May I now request you to kindly take over and start your proceeding. Over to you, sir. Thank you very much.
Thank you, Dr. Manjula, for a reasonable brief introduction about me. And I will start sharing my screen right now. Just a minute, please.
Yes, sir.
liver disease, we need to consider this as a chronic liver disease like pathology. So the patient can have evidence of ascites around 3 to 7% of the population in one large population-based studies that was that it has been proven that, and the patient can develop esophageal varices as well as hepatic NCAF-like presentation around 1.5% of the population, and slowly it has been progressing to ascites and other complication with worsening of your bleeding symptoms and worsening of your encephalopathy, which has been proven in this paper. And because of portal hypertension, like any other picture in the background of chronic liver disease, even in the background for a patient with primary biliary cholangitis can also be supervened in this kind of presentation. Apart from that, primary biliary cholangitis patient is also having increased risk of hepatocellular carcinoma, increased risk of cholangiocarcinoma. All those things can be having a presentation if the patient is going to have hepatocellular, a PBC for a longer duration of presentation. So 0.36 percentage per 100 years have been proven. Higher histological stage, worsening of your histological staging by liver biopsy, there is high possibility for you to worsen up for liver hepatocellular carcinoma. And male sex is being a confirmed risk factor to be proven if the patient is going to have HCC. And how are you going to diagnose this? These are all the clinical presentation. So how do you going to approach? How do you going to diagnose your clinical entities? You have been looking this kind of presentation frequently for all chronic liver disease. And how do you going to diagnose this kind of presentation? So most important, we need to look for the baseline liver function test. So we need to do a serum alkaline phosphatase. So most important, we need to look for other common conditions like any sites also apart from the liver. You need to look for other common conditions like any bony origin as well as from placental. Another source of origin is also there from alkaline phosphatase, and we need to document if alkaline phosphatase is raised or not. So alkaline phosphatase, if it is going to be more than 3 to 5 times of the upper limit of normal, that shows a clear pointer for the patient going to be having evidence of primary biliary cirrhosis or primary biliary cholangitis to take over. So apart from that, once a patient is going to have evidence of high level of alkaline phosphatase, so you need to see a clear-cut approach. You need to see whether it is predominantly because of bony origin, or whether it is predominantly because of any other cause, or whether it is predominantly because of hepatic origin. So how are you going to differentiate that? So you need to do a GGT assay, gamma glutamyl transpeptidase, and other things has to be done properly. Once these things is going to be elevated in this kind of patient, it also shows the evidence that these kind of patients will be having a predominantly hepatic origin, as well as the biliary tract pathology is going to be involved in the management of primary biliary cholangitis. So if the cholestatic symptoms like ALP elevation, if it is going to be significantly high, if it is going to last for more than 6 months, it could be because of intrahepatic. That's what I've been discussed with you, or extrahepatic. So we need to decide whether it is intrahepatic or extrahepatic, where other line of modalities also can be involved in the diagnostic process, like your imaging, ultrasound, MRCP has to be taken over very strongly if you want to diagnose this extrahepatic cholestatic like picture. So jaundice is one common entity like cholestatic pathology, has to be strongly ascertained if you want to manage this kind of presentation. So chronic cholestatic liver disease also have been discussed. Apart from liver, other sources of origin like ALP origin from intestine, bone, placenta, all these things. And always you should remember ALP in a pediatric age group, in a children growing physiology is being very active during that phase. The bony involvement will be very active. So for that kind of children, ALP most of the time will be elevated. And with that kind of presentation, don't label the child as having cholestatic background. And many a times, even pediatricians have been referring the patient with isolated ALP elevation that I would like to point toward most of the pediatricians should remember that ALP elevations alone is not going to be sufficient to diagnose this kind of presentation. So you need to look for other common conditions like any scoring system. And the next line of molecule, what you're going to consider, this is obeticholic acid. That's one of the new entity being considered, and more paper presentations also happening in this, nothing but a foreign X receptor agonist. So once a foreign X receptor, it is going to inhibit your bile acid transfer and other things. So it definitely is going to decrease the ileal uptake of bile acids and decreases the synthesis of new bile acids. So it is having a strong anti-inflammatory and anti-fibrotic. So you can start up the dose by 5 milligrams, you can go up to 10 milligrams, or you can go up to 50 milligrams. There are papers are being reported. But the problem is, once you are going to switching over to high dose of obeticholic acid, we are not very sure. But the one strong condition, what we a strong pointer in which obeticholic acid can be considered in the management right now is for primary biliary cholangitis. So you can have definitely, and in this paper, what they've been shown that if you're going to subject the patient, that shows a significant drop of ALP and other things, your histological changes is going to have significant improvement once the patient is going to subject with obeticholic acid. But if you're going to give higher doses, that shows a worsening of symptoms. Some patient may have worsening of pruritus, some patient may land up with liver failure and other complications. So always you start up with 5 milligrams, not responding for a period of 3 months, step up by 10 milligrams. That is some troublesome complications like pruritus and other things being case reports are being reported. So you need to monitor the patient. Combined therapy of UDC and obeticholic acid can be tried in the management of, as per POISE study, what I mentioned that. So in 217 patients, in serum ALP elevation, non-responder according to modified Toronto criteria, if the ALP, if it is going to be more than 1.6 times of the upper limit, and bilirubin, if it is going to be less than around 2 times the pre-prime. So the primary endpoint will be your ALP value has to come down or less than 1.7 times, and your bilirubin has to be normalized as per your modified Toronto criteria in your POISE study, what have been taken. So that shows around, if you're going to use a dose of around 10 milligrams, 47% of the patients definitely is going to improve, and the dose titration has to be managed successfully. So this is how obeticholic acid so also may exhibit alterations. If you're going to subject the patient with obeticholic acid, there may be lipid alteration, and the decrease in HDL cholesterols and total cholesterols can be there. And once the patient, as per EASL recommendation, the approved indication is PBC management in combination with UDCA, obeticholic acid can be tried. So initial dose 5, as I discussed, can be titrated up to 10 milligrams. So other drugs, so many other drugs which is not much of use, like immunosuppressive molecules, methotrexate, cyclosporine, mycophenolate, depenicillamine, colchicine. So many other drugs can be tried. And one example is budesonide. It's having an anti-inflammatory effect that what I've been trying for inflammatory bowel disease. And you can go from 3 milligrams twice daily, or one dose of 9 milligrams can be tried if you're going to manage the budesonide. But once a patient is going to subject with budesonide, there's significant beneficial effect. The liver histology doesn't show much of alterations, and longer benefit and the longer duration, prolonging the survival is not going to have a significant impact. Apart from UDC, obeticholic acid, the overall percentage with other drugs is not being showing any significant beneficial role if you're going to subject the patient with budesonide. So open label study, what they've been showed, a non-responders of persistently high alkaline phosphatase shows very minimal benefit with budesonide when subject the patient along with UDCA support. This is how the second line of molecules like immunosuppressive, like methotrexate, can be tried. There are some papers, some experts have been using methotrexate also over a period of time, but shows a minimal improvement, but no much of significant benefits have been reported based upon a histological presentation and other things. Fibric acid derivatives in hypertriglyceridemic like presentation
So there's one follow-up question to pathomechanism. What are the characteristic histopathological picture of PBC?
The predominant will be a ductopenia, as what it is, a florid duct lesions, fibrotic changes. That's the most common histopathological. As the day progresses, the patient can land up. That's what I've been shown in Ludwig staging. Now, so the stage 1, 2, initially the cholangitis state, followed by the hepatocyte involvement, followed by the patient can go for fibrotic, followed by the patient go for cirrhotic changes. The ductopenia and other things is going to take on.
So this next question is, what is the role of immunosuppressive agents? Hello.
Immunosuppressive agents can be considered in the management of primary biliary cholangitis, but the role has not been proven a significant beneficial effects. Like when you're going to consider methotrexate, when you're going to consider, for example, azathioprine, when you're going to consider mycophenolate, can be tried, but how far it is going to have a significant beneficial role, and based upon how the complications you are going to prevent in the management of primary biliary cholangitis is definitely a questionable issue. So it's all been trial and error, but strongly determined pointer as of now will be UDCA, and second molecule will be obglycolic acid.
So that question was from Dr. Rajesh. Sir, there's one more question to follow up. We know that although PBC is described as an autoimmune disease, but as you know, immunosuppressive agents have not been shown to provide that sustained efficacy in therapeutic option. What is your comment on that, sir?
Mainly because even then it's because of the autoimmune pathology. The problem is it's going to involve in the complete destruction of your bile duct nature. So once a patient being distorted with your bile duct nature, so the patient even then, if you're going to subject the patient with autoimmune immunosuppressive molecule, the potential beneficial role is definitely not going to happen. And the early phase, the cholestatic picture is not going to improve, because autoimmune hepatitis is predominantly mainly because of the liver involvement, and this is mainly because if your biliary pathology is going to be absolutely a different molecule, different area to supervene. And these are all the other things to be considered if you want to manage a patient. And apart from that, immunosuppressive can be considered, but so far the successful beneficial role and the avoidance of liver toxicity is not going to be seen. So definitely the patient will be managed with immunosuppressive agents only. Enzyme levels, and apart from that, it is having a strong potential role in bringing down your pruritus, and based upon your hepatocytes inhibiting your anti-apoptotic activity and inflammatory pathology in cholangiocytes, all those areas have strong beneficial role. Even in your ileal transport mechanisms, even the ileocytes and even in your monocytes is going to have a significant impact. It reduces the cytokine production. All those autoantibody reduction will be there if you're going to subject the patient with UDCA. But high dose of UDCA definitely not much of beneficial effect. Low dose of UDCA also a questionable issue. The normal dose around 13 to 15 milligrams per kg per day or a period of time around 1 to 2 years can be considered if you're going to manage a patient with liver, manage a patient with PBC.
Sir, how to administer bile acid sequestrants along with UDCA, sir?
So that's a good question. If you want to administer bile acid sequestrants, you should not give the molecule with UDCA. Either you need to give UDCA 2 to 4 hours prior, or you need to give bile acid sequestrants 2 to 4 hours prior. Don't combine two molecules together. And if you're going to give sequestrants like cholestyramine, you need to use normally a juice formulation, because most of the time it will not be edible. So you can combine with juice 4 grams per day, and you can step up to 4 times a day. You can take but there's most of the time the duration should be around 2 to 4 hours of gap should be there when you're going to take UDCA with your bile acid sequestrants.
Sir, is there any role of budesonide in PBC? If so, what is the dose, sir?
So there is some beneficial role of budesonide because it is also an anti-inflammatory agent, strong antifibrotic. But what's the main thing? If you're going to consider budesonide, the potential indication already been proven for ulcerative colitis. But in this previously, the same molecule, same methodology has been tried, but the successful beneficial role in bringing down the histology has not been well addressed as per various studies which has been conducted. So in case if you are going to use that budesonide, either you can give 9 milligrams orally stat dose of 9 milligrams once a day, or you can give 3 milligrams twice daily. These two multiple studies, there was single dose regimen also been 3 times a day regimen also been tried. But based upon that, the paper, the beneficial role, the histological prevention, the prevention of liver transplant definitely is not going to halt if you're going to subject the patient with budesonide support.
Sir, what about MMF, sir? Mycophenolate mofetate.
Mycophenolate
That
mofetil
might
can also be considered. I think I didn't add it in my due to lack of time, but that also can be considered along with the second line therapy like azothioprine and other things. And autoimmune hepatitis overlap can be considered, but still we need more papers to validate all those things. No strong beneficial effects.
right. Sir, is there any newer FXR agonist being tried, sir?
There are multiple newer effects or agonists being tried, like I think of we need to remember that apart from we know that obeticholic acid is one strong thing. Apart from that, cilofexor and trifexor, all those things can be tried. But in 2020, there are some case reports there to consider cilofexor and trifexor. But we need more papers in India to validate all those things.
Correct. Sir, can we use 50 mg of obeticholic acid, sir?
We can use, but how far it is going to be beneficial is questionable issue. As of now, I have tried up to 10 milligrams only. In my experience, I didn't go up to 50 milligrams to be to say the real truth. But what the experts are meaning for 50 milligram dose, if you're going to use for 50 milligrams, there are worsening of your pruritus is definitely going to be very high. Sometimes you may land up with liver failure. You can develop acute liver failure. You can develop acute or chronic liver failure. Other kind of presentations also can happen if you're going to use obeticholic acid at a very high dose. So very high dose doesn't going to yield much of the beneficial effects. Always you need to consider at a moderate dose regimen.
Sir, do you use S-adenosine methionine, sir? Sam.
Can be considered. S-adenosine methionine can be considered in the management of hepatic NCAF, other causes to halt the cirrhosis. We can consider the dose of 1,200 milligrams per day for a longer duration of around 1 year to 2 years can be considered in the management. But those are all add-on therapies can be initiated once a patient is going to land with complications like cirrhosis and other things going to take on. But main modality is not SAM.
Yeah. So there's one question. What is the role of fibrates in pruritus?
Good question. Actually, I want to discuss that. Fibrates and pruritus now on the triple drug therapy like obeticholic acid, fibrates, UDCA can be combined. So fibrates, if you're going to use fenofibrate, if you're going to use bezafibrate at the dose of 4 milligrams per day, there is a strong potential beneficial role. It's going to reduce the triglyceride levels as based upon the pruritogenic pathology is going to come down, and it's going to have an impact in your pruritus also. So even for xanthomas, other complications which is going to happen because of your high level of fibrates is going to get deposited. So these are all things where you're going to have a significant impact if you're going to use fibrates to prevent your complications like hypertriglyceridemia to supervene. So fibrates can have a beneficial effects in management of pruritus as a triple drug therapy, but not as a monotherapy.
Sir, do you use UDCA in recurrent PB, sir, after liver transplant or anything? Do you use?
Yeah. After liver transplant, no other ways to prevent that. We need to consider the patient again for transplant, or else we need to consider still the same line of modality of treatment, like PBC, like UDCA, or which acid can be considered because there are high potential possibilities since it's autoimmune pathology. 10 to 30% of the patients can go for recurrence of PBC as the day progresses.
Just now you mentioned about combination therapy. How commonly or how often you go for combination therapy, sir, in PBC?
So we need to monitor the patient how far it's going to respond. First, we need to make a clinical diagnosis. That itself is a very complex phenomenon. Once a clinical diagnosis is going to make, serially monitor the patient, subject the patient first individual CS support for a period of 3 months, see whether the patient is responding or not. Not responding at a second line of drug like obeticholic acid, then assess the response. Once a patient been subject along with liver complications, look for evidence of hypertriglyceridemia, bone pathology, other things. If you're going to be there, supplement vitamins, and then at that point of juncture you can add fibrates and other things.
So what you're trying to say, mostly it is UDCA in the beginning, and most of the patients you put them.
UDCA to start with and
Yeah.
serially follow up over a period of 3 months, and then you can add other line of molecules in case based upon your clinical symptoms which is presenting or improving or worsening.
Okay. Do you use any just on alternative therapy, sir, in this case? Since India, a lot of alternative
Alternative therapies,
therapies.
see, I will say one
Uh,
thing: milk thistle been tried.
yeah.
Okay, milk thistle. If you are going to look at
Silimarin. Yeah,
silimarin,
Silimarin.
it's definitely having a significant role, not only for that, but milk thistle as alternative line of therapy can be considered because even for acute viral hepatitis, if you are going to look alcoholic hepatitis, silimarin is going to have a significant potential role. And apart from that, milk thistle is having a potential, minimal beneficial role. But how many drugs we can try in the management of PBC? It's definitely not much of beneficial clues are being there.
Right, sir. Yeah. Swakshar, are there any more questions in the YouTube? You are muted. You have to unmute. Yeah, yeah.
A very excellent, informative talk, Dr. Arun. Great going with
Thank you very much,
good
sir.
discussions. Yeah. So appreciations are coming for Dr. Arun
Very
from
much.
different doctors. And one question is the Dr. Exponential talk, the pathomechanism of pruritus.
Yeah, that has been answered.
No, that's it. That's it. That's it. Nothing else. Yeah.
So there are a lot of positive comments here,
Yeah.
sir.
Comments. Yeah.
Excellent talk, informative talk,
Yeah.
good discussion, right?
Yeah.
So I think
Yeah.
we have actually exceeded the time, sir. In fact, in this. So if there are no question,
Thank you very
can we?
much.
Yeah, thank you so much, sir. It was really very, very informative. Now over to Dr. Harsha. You would like to say something? Then over to Mr. Swakshar to close the meeting. Yeah.
Yeah.
Dr. Harsha would like to say.
Nothing much, man. It was excellent session, sir. I think I learned a lot today. I came to know that there are so many treatment options for PBC management. Thanks, sir. Thank you,
Thank you
sir,
very
for
much,
that
Prakash.
excellent presentation. Thank you.
Yeah.
Okay.
Thank you. Yeah. Thank you, sir, for giving a broad insight into the management of PBC and approach towards PBC. What are the various therapies available for the management of PBC? It's really an enlightening talk what you've given, and we look forward we'll have many more interactions with you in same line on different molecules and as well as on different indications and all. Thank you so much, sir, for being a part of this.
Thank you very
Yeah,
much.
Thank you very much,
thank
sir.
you,
It
Thank you
was
very much to share your time in this wonderful
excellent, sir.
setting.
Thank you. Namaste.
Thank you, sir. Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you all the
Thank you, sir.
Thank you all.
viewers for being here.
Bye.
Thank you.